morning. Good morning. Good morning. Okay.
Afternoon, actually.
Or afternoon. Welcome to lunch. So I'm Dr. Rob Snyder. I'm Dean and Professor and Research at Barry University School of Podiatric Medicine. And on the podium with me today, I have Kathleen Sham, who is President of the Kathleen Dean Sham and Associates. She's extremely well known in coding, and you'll get a lot of information from her. And we have Dr. Eric Luloff, who is the Chief Medical Officer, West Boca Center for Wound Healing. These are the disclosures, and these are the topics. I'm going to start off just basically by talking about an overview of the product, an overview of wound healing, and a little bit about some indications for ActiGraft. And then we're going to move to Kathleen's talk on coding and coverage, and then recommended documentation with Dr. Luloff. So you're all familiar with this kind of patient. This is someone we see every day in our practices, and of course, offloading, debridement, moist wound healing, collagen dressings, etc. But very often, these patients still don't heal. So when they don't heal, what do you do? Well, there are many alternatives. Hopefully, after this talk today, you will realize that there is an incredibly important alternative that is now out there and available for you to use on these very difficult patients. Something else to keep in mind, obviously, we all need an algorithm when we treat these patients. And I like to use the wound bed preparation model. It's very simplistic, but it's very powerful. First and foremost, is the patient healable at all? What is the underlying etiology? Does the patient have a wound, or does the patient have cancer in that wound? We have to look at patient-centered concerns. Very, very important. What's their vascular disease like? Do they see their primary care physicians on a regular basis? What's their lipid profile, etc.? And only then can we actually talk about the wound itself. And there's a very easy acronym to remember. It's DIME, D-I-M-E. You may have heard it as T-I-M-E. T for tissue. I like D-I-M-E, D for debridement. So it's debridement, control of infection, inflammation, moisture balance and imbalance, and wound edge preparation. So I want you to kind of keep those in mind as we move along, because wound bed preparation is not only important to make a diagnosis and treatment, but it can really help to prevent infection. That's my son, by the way. Anyway, sometimes despite our best efforts, we still can't get these wounds to heal. We use all the algorithms we think should work, and they don't work. So it's kind of like pushing a boulder or trying to lift a 300-year-old tree that's been cut down. It just very often is very difficult. And here he is again. So today we're going to, at least in my talk, we're going to look at the biochemistry of acute and chronic wounds. We're going to talk a bit about ActiGraft, which is very important. We're going to hypothesize a mechanism of action as to why we feel this works. We're going to look at some of the evidence relating to this and also some potential indications for this therapy. So here's ActiGraft. It's an FDA-cleared product. It's a proprietary patented technology. And basically, we take blood from the patient's arm at chairside or at bedside, and we clot it. I'll show you how to do that in a little while. And then we put it directly onto the wound. It acts as a supportive matrix for keratinocytes to move across, but it also bathes the area with significant numbers of growth factors and other substrates that are required for healing. This is Red Dress founder, Eagle Kushner. He's a medical doctor out of Israel, and he actually developed this product. So what is the problem? Well, is Greg Schultz in the audience somewhere? No? Okay. Well, this was Greg's slide, and I think it's really very important when you realize that one of the major issues of wounds that don't heal is because they're stuck in the inflammatory phase of wound healing. They just won't move into the proliferative phase of wound healing. Now, this is kind of a very simplistic overview, but what I want you to understand here is there's an overlapping of of situations occurring here. So you're going from inflammation to the proliferative phase and ultimately the reparative phase in these overlapping phases. And they're all happening simultaneously. So it's a very complex dynamic, but it's very orderly and it's very predictable. That's why we can make incisions in people's legs and take sutures out in 2 weeks and the wound doesn't flop open. So when do you think about this? Well, you think about it the same way you would think about your television set or your computer. You think about it when it doesn't work. So basically, this is a kind of a brief overview of what we're really talking about when you think about a chronic wound. Of course, you have unresponsive or senescent cells. Cells are not dead, they're just asleep. And very often, if you don't do anything to proliferate those cells, you have what's called replicative senescence. You have a non-migratory hyperproliferative wound edge, so keratinocytes can't move across the wound to reepithelialize it. But something else is important as well. Very often the wound edges will curl and they'll seal off, a concept called epiboly, which I'm sure you're familiar with. And the body just basically says the wound's healed and doesn't do anything. We have high levels of proteases, which we'll talk about in a moment. We have deficient or unavailable growth factors or unavailable receptor sites. I thought we were being attacked. Okay. You have bacterial interference. So bacteria in and of itself at high levels is going to allow the wound to remain in that inflammatory phase of wound healing. But something that people don't realize is bacteria in and of themselves will release their own enzymes, endotoxins and exotoxins. And that could have a deleterious effect on wound healing. So even though this is a model of the diabetic patient, it really applies to all chronic wound biochemistry. And now, of course, we add another factor to the mix, and that is the biofilm. And certainly that could be a significant equalizer as to why these wounds don't actually heal. So this was a study done in 1999. It was done by David Margolis at the University of Pennsylvania. They did a meta-analysis looking at whether or not standard care would heal a chronic wound in a patient with diabetes. It's a meta-analysis. What they found, unfortunately, was at 12 weeks, about 25% of patients would heal, and at 20 weeks, less than 31% of patients would heal. Not very good news for us because we began to realize even back then that when you are treating with standard care, very often these wounds will not heal. Now, there was a more recent meta-analysis. Actually, this was a larger one done on 16 randomized controlled trials. If you look at the healing rates here, and you look at 12 weeks, it's about 33% healing. And if you look at 20 weeks, it's 43% healing. So it's better than it was 20 years ago, but not much better. The endpoints have not dramatically changed. This was a study that I did, basically looking at a surrogate endpoint of 4 weeks to determine whether or not we could predict healing by week 12. And of course, there was an original study done by Peter Sheehan several years before. What we found in this study was that if wounds didn't progress by 50% area reduction within the first 4 weeks, the likelihood of healing was very, very low, 2 to 5%. So just to kind of put that in perspective, if you reverse those numbers, 95 to 98% of wounds will not heal unless they reach 50% within the first 4 weeks. But even with that 50% in the first 4 weeks, greater than 45% of wounds still didn't heal by week 12. So what did this tell us? Well, it gave us a sense of urgency, number one, that we have to treat these wounds early, particularly if we're seeing wounds that are not reaching that endpoint of 50%. But what about that next 8 weeks? What about those individuals that still don't heal within that next 8-week period? So we took the same study, we expanded it. My mentor, Robert Warner, has unfortunately passed away. But he and I looked at this very carefully, and what we found was there were 2 additional surrogate endpoints as well. One was if a wound deteriorated or did not improve between 4 and 6 weeks, or if the wound didn't reach 90% area reduction by week 8, it would not heal by week 12. Now, when you think of 8 weeks versus 12 weeks, it doesn't seem like a lot, but let me tell you, if you're a diabetic patient with a wound, 4 weeks is a lifetime. The extracellular matrix. The extracellular matrix is in the largest structure of the body. What is that? Skin. Skin is an organ. Skin is the largest organ in the body. And you have this extracellular matrix which actually acts in several ways. Number one, it's the infrastructure for the wound. It's also gelatinous, so it prevents shearing. But as you will also see in a moment, it has a communication effect as well. So when you look at proteases, and we talked about the fact that there are elevated proteases in chronic wounds, the two that we see most often are serine elastase or neutrophil elastase and matrix metalloprotease. Now these are very often controlled. They're really in an inactive form until they're ready to be utilized. But what tends to happen is, even though they're functioning physiologically correct, when you have a problem with excessive proteases, what occurs is that entire extracellular matrix can be destroyed. So two things occur. Number one, that infrastructure is gone, but just as importantly, there's something called dynamic reciprocity. What is that? Well, basically it means that there's a communication between the cells in the extracellular matrix and the cells in the wound itself, like fibroblasts and endothelial cells. So if you lose the extracellular matrix, you disconnect that communication between the extracellular matrix and the wound cells. So the wound doesn't heal. So another important thing to keep in mind, and autologous whole blood clots certainly could serve to bolster this extracellular matrix. The clotting cascade. I'm not going to spend hours talking about the clotting cascade. It's very, very complex. There are 13 clotting factors. What I want you to realize here is that the complement cascade has been shown to play a role in inflammation and also augmenting wound healing. Macrophages. We're all familiar with macrophages and what they do. Macrophages create phagocytosis. They ingest bacteria. But they do something else as well. There can be pro-inflammatory macrophages, which we call M1, and they can be anti-inflammatory macrophages called M2. And what we want to do is we want to move out of the inflammatory phase of wound healing so that those macrophages, M1, become M2. Something I want you to keep in mind, and of course it's going to be the prelude to what you're going to hear in a few minutes. This is the new National Coverage Determination, which defines cell requirements. I'm going to read it to you. The PRP is different from previous products in that it contains whole cells, white cells, red cells, plasma, platelets, fibrin, stem cells, and fibrocyte precursors. So I want you to keep that in the back of your mind as you listen to some of the other lectures. So we can hypothesize, at least at this point, how this whole blood clot actually works in healing wounds. First and foremost, it can function as a sealant. It seals the wound edges off. So bacteria that are sitting in the peri-wound cannot get in. It also could, at some point in time, act as a drug delivery system. So that's also very important to keep in mind in the future. It contains multiple growth factors, some that we don't even know exist at this point. And of course, this can increase vascularity via angiogenesis. It could prevent infection because you have macrophage intervention, and also you're sealing the wound edges off so that bacteria won't get in. It fosters contraction, it bolsters the extracellular matrix, and it could stimulate pluripotent stem cells to come to the area as well. Another way to think about this is very likely, and again, this is theoretical at this point, but it seems to make sense. It's very likely that the extracellular matrix in the chronic wound bed may just signal the wound to give the wound what it needs when it needs it. So you have this whole blood clot with all of these growth factors and all of these substrates, and you're now trying to figure out what is going to happen at what time. So again, theoretically at least, we think that there's this communication which allows that to occur. And that's basically what the blood clot looks like with ActiGraft. So we have angiogenic stimulators and we have angiogenic inhibitors. This is a very interesting concept I wanted to share with you. The concept of therapeutic angiogenesis is aimed at topically applied growth factors, giving them in excess. And when you give them in excess, this could override the inhibitors that we have against angiogenesis. So again, thinking about whole blood that's topically applied to the wound, certainly you can produce and overproduce growth factors, and this will stimulate angiogenesis. And that could conceivably be what it may look like. So looking at advanced therapies, of course, we have autologous, allogenic, and xenographic. Examples of autologous would be split-thickness skin grafts or PRP. Allogenic would be living skin equivalents or amniotic membranes. And xenografts, of course, could be porcine, bovine, etc. So why autologous? Why would we choose that? Well, there are several reasons. Number one, it's biocompatible. It reduces the risk of getting an infection from something that's not autologous, and there's a minimal chance of rejection. But these are the things I really want you to look at carefully. The autologous whole blood clot does several very significant things. Number one, it has a supportive matrix. It's a biologic scaffold. It stimulates the normal healing cascade. Unlimited resource. Your body keeps producing blood. So it's an unlimited resource. So it's never going to run out. And of course, because it's effective, it can be cost effective as well. And this is what it looks like under electron microscopy. You can see that stromal matrix, but you also see those keratinocytes sitting there as well. So let's look at some of the evidence. This is a study that I was involved with a couple of years ago. It was published in Wounds, and these are the results. We kind of looked at 20 patients in an open label study. We found that at the end of 12 weeks, the intent to treat group healed 65% of the time, and the protocol group 72% of the time. And if you look at the mean time to wound healing, it was about the same in both groups. Now, there is a pivotal randomized controlled trial in the works currently, which is going to compare this product, the ActiGraft, to standard of care, offloading, moist wound healing, and debridement. So this is just an example of all of the articles that have been published over the past couple of years. Many involve, as an example, complex wounds. We always have difficulty trying to cover wounds that have exposed bone, tendon, or muscle. So this is a very, very important potential therapy for that. We're also conducting a registry, and right now we currently have 150 patients, probably a little bit more at this juncture, and we actually published the initial results of that registry study. And this is what it looked like. It was 29 patients with diabetic foot ulcers, chronic wounds. We used this blood clot therapy. Again, you draw blood, you use calcium gluconate to help with the clotting. You then remove the blood, you put it in this little dome with kaolin in it, and it clots. And it kind of looks like a hockey puck. It's very malleable. You can actually cut it, and you put it directly onto the wound. So this is the results that we got. About 76% of patients achieve 50% area reduction within the first 4 weeks, and 95% of all wounds in this study healed within 12 weeks. So I think it's pretty safe to say that autologous blood clot therapy applied topically is superior to standard of care, creates wound contraction, protects against bacterial invasion, etc. And this is just an example of what it looks like before and after treatment. These are some other articles that we did. The one I want to focus in on real quickly is the fact that we did 2 consensus documents. So why 2? Well, number one, we wanted to set the stage for the second one. So the first one was really to kind of introduce the whole concept of utilizing topical whole blood on a wound. And the second one was really more of a deep dive. So here's basically what we discovered. We already talked about the benefits of whole blood applied topically, but where can you use it? Well, certainly it may have benefit in wound bed preparation, in dealing in some form with biofilm, sort of protecting planktonic bacteria from getting into that wound, tunneling and undermining. You can use it on complex wounds. This is really very important because, again, exposed tendon, muscle, bone, very difficult to cover. We have very few options in that regard. Non-surgical candidates, patients who have no other option. This is something that we can try. Again, it's very, very easy for the patient to tolerate and very, very comfortable as well and could be very successful. Arterial wounds also could be a benefit. And this is the second paper that we did. This is the consensus document, and we basically went back to the wound bed preparation model. And in every phase of the wound bed preparation model, the DIME, we found a place for this whole blood clot therapy. So as an example, for debridement, let's say we have a patient we can't debride. So this would be a good methodology to use. Certainly infection, we talked about the importance of macrophages, but also the fact that that wound is sealed off by the blood clot. Thirdly, moisture. Of course, this is creating a very important moisture balance. But at the end of the day, wound edge preparation is critically important. And again, not only do you have contraction, but you also have a protective barrier so that bacteria will not get in. This is some of the current investigations that are now ongoing. They're looking at anal fistulas, at polynoidal cysts, soft tissue regeneration, bone, nerve, etc., Flowable therapy. I think this is the next frontier because, again, when you have these tunneled and undermined areas, it could be very, very important to be able to inject this whole blood in a flowable form into those areas. So this is just an example of what a wound would look like after it's prepared, and now we're applying the whole blood clot therapy, and this is what it looks like when it's applied. Very simple to apply and really held in place with Steri-strips. So the takeaways are as follows. Number one, topically applied autologous blood products can manage healing. Number two, you stimulate growth factors, cell migration, you mitigate infection, it bolsters or replaces the extracellular matrix. It's evidence-based, it's easy to use, it's very comfortable for the patients. Patients will accept it. They will accept it because, again, they're all used to having blood drawn. There's a continuum of care. It's cost efficient, and at the end of the day, it supports natural healing. So that is the end of my talk. I'm now going to turn it over to Kathleen, who's going to talk about coverage, coding, and payment. So thank you very much.
Thank you. Well, good afternoon. I am glad to see you all here, and I'm honored to be here. This is quite a prestigious meeting, and it's great to have lunch with you today. The disclaimer, any of you who know me for reimbursement, is that I can tell you a lot about coding, payment, and coverage, but I can't guarantee you're going to get paid. And the information that we gave you, you know, you had to prepare the slides ahead. So it was current as of October 30th, but it's going to be up to you to really be sure that you check with the payers of your patients about the appropriate coding, payment, and coverage for this particular product. Now, we always protect the trademarks, and so CPT is a trademark of the American Medical Association. And what are the objectives of today? Those of you who have been to my reimbursement programs know that we always talk about three things: coding, payment, and coverage, because it takes all three to be reimbursed. And typically, we talk about coding first, then payment, and then coverage, because I'm always giving you a warning about coverage. But today, I'm so excited, we're going to talk about coverage first. And then we're going to talk about the coding for the product and the procedure, as well as the diagnosis codes. Then we're going to talk about how outpatient departments get paid, how physicians get paid, and then I'm going to emphasize the importance of documentation. Very, very important. So, why am I excited? I am excited because you've heard a lot about coverage recently for certain categories of products throughout the United States, and we are so thrilled that we have a national coverage determination, which it is, and the national coverage determination number is 270.3, and it is for blood-derived products for chronic non-healing wounds. It was effective on April 13th of 2021, so it has been in place for a while. And if you don't know about it, this is great news for you. Because once there is national coverage determination for Medicare, it means that all your MACs, all of them, must cover the procedure. Right? It's not up to them to decide, do I cover it or don't I cover it? They all must cover it. And in the national coverage determination, it says that the procedure may be performed for chronic, non-healing cutaneous wounds that persist for 30 days or longer and fail to properly complete the healing process. Just keep that in mind in light of what Dr. Snyder has just talked to you about. The National Coverage Determination also addresses non-healing diabetic ulcers. And it says we cover chronic, non-healing diabetic ulcers. But it also says If you want to use this on other types of ulcers, that is going to be up to your Medicare administrative contractor. So nationally, all the MACs must for diabetic ulcers, but if you want to use it for any other type of an ulcer, you would have to verify with your MAC if indeed they cover it. And the other great news is that the National Coverage Determination says it is covered for up to 20 weeks of application. Now, I doubt very much you'll need this for 20 weeks for most patients, but that the good thing is that it does cover it if it's medically necessary. You don't do it just to keep billing for it, all right? But you can do it up to 20. Now, also in the National Coverage Determination, it reminds you that you need at least 2 diagnosis codes. You have to have the diagnosis of a diabetes mellitus with an ulcer, so one of those specific codes, and then you must have one of the chronic ulcer codes. So if you don't have a diabetes mellitus with ulcer code and a chronic ulcer code on your claim form, then you can count on it. It will be denied. All right? Now, where can you do this? The covered places of service, there are 4. You can do it in the office, which is place of service 11. You can do it in an off-campus hospital outpatient provider-based department, which that one is called, the place of service is 19. And if you do it on an on-campus provider-based department, the place of service is 22. So office, off-campus provider-based department, on-campus provider-based department, and an independent clinic. And an independent clinic is, most of you probably aren't this, because it is a location that there is no other place of service for, and almost all of you do your work in some place of service where there is a place of service code. So basically for you, it's pretty much 3, 11, 19, or 2022. So don't ask me if you can do it in the home. Why? Is the home one of those? No. All right. So don't ask me if you can do it in a nursing home. Is that one? No. All right. So I'm just bringing that to your attention. Those are the places of service. Now, what are the codes for this procedure? I've talked to you that it is covered for chronic diabetic ulcers. Therefore, this is the second code on the slide. G0465 is the code that you would be reporting if you are doing this for a diabetic chronic ulcer. If you are going to try to get it covered for some other type of an ulcer, you use G0460. Notice that that's for non-diabetic chronic ulcers. I'm making a pretty big deal about this because when the National Coverage Determination first came out, there was only one code, and it was G0460. And you might have that in your charging system, all right? And then if you went to use that today for a diabetic ulcer, and you build G0460, notice they changed the definition. So G0460 should not be used if you're doing this on diabetic foot ulcers. It needs to be, or any diabetic ulcer, you need to use G0465. All right? Now, remember I also told you that this is covered for up to 20 weeks. But in the National Coverage Determination, it says if you need to use it more, then it would be up to your MAC to determine if indeed they would allow you to. Well, they even made this a little easier for us, because if you have a patient who is moving along, and very much you're showing improvement, everything's going great, and you reach the 20th week and you need a few more weeks, all right? If you have excellent documentation showing that this treatment has been working, but you need a little more, you can bill the G0465 again, attach KX modifier to it, And be sure that your documentation is impeccable, showing that why do you need that? Because most likely, when you submit that particular claim, you might get asked for the documentation before they pay it. But if you have really done your job well, you should be able to get payment for that if it is medically necessary. So bringing that to your attention. Now, as I told you, the codes changed since the beginning of the national coverage determination, as well as just this July 1st, the code definitions changed. Because at first, the codes were, you had to use a centrifuge in order to do this procedure. But they changed it because technology moves along, and they changed it from just being autologous platelet-rich plasma, and it adds or other blood-derived products. And then it says using an FDA-cleared device for this indication. And it includes the administration, the dressings, the phlebotomy, the centrifuge, or mixing, or mixing, and all other preparatory procedures per treatment. So I want you to understand then that there's some technology you need at a centrifuge and some you do not. All right, now, how do you get paid? In the provider-based departments, we know that codes get assigned to ambulatory payment classification groups. And this particular code, G0465, is assigned to APC group 5054, and the national average allowable rate is $1,725.86. Now, in your provider-based departments, there's probably not one in the country that gets exactly that, because every one of your provider-based departments has its own wage index. So you might get a little higher, you might get a little lower, but that is the national average for that procedure done in a provider-based department. Now, for the physician, all right, Medicare never, ever publishes an allowable rate when there's a G code for the procedure. Nothing wrong with the G code. It's just a new procedure. They give it a G code. So when it has a G code, since there is not a published rate by Medicare on the physician fee schedule, then it is up to your individual MAC to what they're going to pay. Because remember, they don't have a choice about coverage. They have to cover it because it's a national coverage determination. But they do have a choice about what they're going to pay. And so you, as providers, really should communicate with your MAC medical director if you want to use this advanced technology and teach them the clinical benefits of why this was good for your patients, and teach them what's your cost to perform the procedure and what cost savings you might incur, which I can think of a lot of cost savings you would incur with this particular procedure. And ask them, please publish an allowable rate on your fee schedule that is fair so that indeed we can afford to do this. And of course the manufacturer also helps to communicate with the MACs, but I have to tell you, the manufacturer could communicate all day, every day, but the MACs want to hear from who? You, the user. They want to hear, particularly from the physicians, the nurse practitioners, PAs, the podiatrists, etc. They want to hear from you that this is important to you, it's important to your patients, and they should put it on their fee schedule. And it's on a lot of fee schedules right now, but it will grow and grow and grow with your utilization and your education to your MACs. Now, so you see, we have positive coverage, yay. All right, we have a code, yay. We have payment. All right, now the most important thing to you is documentation. And I'm going to tell you a little secret. You know, I do consulting work all over the country, and I do education for providers like you. And in so doing, I get a lot of calls when people are going to have an audit. And when they're going to have an audit, they particularly tell me, Oh, I got audited for debridement. I got audited for CTP. I got audited for HBO, whatever. All right? And when I read, and then they want to know why didn't they get paid? Okay, why did they have to pay the money back? And I have, over this last year, paid a particular attention. If that audit, let's say they're getting audited on debridement, if that audit had been on HBO, they would have still failed. If that audit had been on surgical dressings, they would have still failed. Why? Because they failed to document their basic wound care to show medical necessity for everything else they do. So I'm saying to you that in your documentation it's vital that you have very, very clear picture of your history, your duration, your management of the wound or ulcer, that you have clear assessment and diagnoses identified in the medical record. You have a plan. I don't know why I went, can you hear me still? You have a plan of care for every wound, not just the patient, but for every wound, that you have medical necessity for the procedure, you document the complete procedure, and if you need more than 20 applications, you document. With that, I am going to now turn it over to Dr. Lulov, who is going to show you the recommended documentation practices that he implements in his business.
Thank you. Okay. How was lunch? You guys ready to go into coma so you guys can all pass out during my presentation now? Before I get into the documentation, how many in the room are MDDO, PA nurse practitioners? Nice. And RNs, PTs? How many of you actually really do your documentation? You all lie, whatever. Okay. Okay. So, inasmuch as Kathy was great at talking about what the NCD does cover, it's really important to know what it doesn't cover, okay? And I can guarantee you there's somebody in the room sleeping in the back row somewhere who will do this, okay? And it doesn't cover the non-acute, the chronic non-healing cutaneous wounds, because remember, the NCD specifically said diabetic wounds, right? It will not cover the clamperin or anything anything that's non-autologous, okay? And it won't cover autologous PRP for anything but a diabetic chronic wound. So you can't do a spin-down PRP in your office and bill this code, okay? So the procedure itself, and this is our YouTube video, so we're gonna go through this real quick. So you get everything in the box. It's a plug-and-play product. So this is everything that is included. You do the blood draw, the phlebotomy. You're gonna drop 2 vials. So this is the new ActiGraft Pro kit that has all the new toys to play with to do the actual clot formation graft. Typically, I allow it 8 minutes to coagulate, but 5 is the minimum. No, both vials. You will get some excess drainage, it's okay. All right. Okay, I'm done. Just kidding. Okay. So that's basically it. You can, if you have to, you may cut that down to specifically size the wound so you don't have so much overlap, where you can get a little bit of moisture-associated skin damage from excess graft. But for the most part, I can always take care of maceration afterward. What I can't do is not heal something that's not healing. So that's just my little caveat. Again, I'm going to reiterate the claims documentations for chronic non-healing diabetic wounds. The only thing I'm going to change a little bit about what Kathy had talked about was that in her slide she had diabetes mellitus with ulcer. You must have a diabetes code, whether it's an E08, E10, E11. That has to be some sort of metabolic diagnosis code, and then your chronic ulcer code, your L97s. Okay? So it's not so specific to the ulcer, but you want to document, because what if the patient might have acquired diabetes from, say, chemotherapy? There's a specific code for that. That might be the cause of why they have the wound. So that's the whole idea of the two specific code sets. In your progress notes, you have your HPI, you do your meds, allergies, you do everything else you normally do. Past medical history for every encounter. The reason why is because you are setting up a clinical context for using the product, okay? The clinical context isn't going to change week to week. However, it will if there's a new complication during the course of therapy, and it's important to have that documented, okay? Specifically, before you start therapy, this is in that plan, and your plan is what failed the wound prior, okay? And it doesn't have to be anything that you've done as the clinical provider. It could be just from previous treatment history. It could be the patient's now referred to your clinic, but they had 4 months of care by the primary care physician, okay? It could be that they never sought treatment. It could be anything related in the history, but you have to have it well documented. And the important thing is you list everything. And I know it seems like kind of long to do this, or kind of laborious to do all this documentation, but trust me, you are going to be better for it at the end of the day, because you really only have to do it one time. Important are the biomechanical changes. If the patient has a sub-first MPJ wound, okay, and they have hallux rigidus, you need to document that. Patient has decreased range of motion of the first MPJ, which is causing increased plantar foot pressure. Okay? They have an equinus condition. They have a cavus foot. Okay? Remember, these are diabetic foot wounds. So the biomechanical assessment by your podiatrist or your podorthist or even an RN clinical assessment, you just can't say the patient has a diabetic foot wound. Okay? There's a reason why patients develop DFUs, and it's usually biomechanical and metabolic. So this is your checklist. This is a inclusive list, but it's not encompassing. I'm not saying this is you have to have all this, but it's usually a good idea. The big one is the ABI. So if I honestly raise your hands, how many of your clinics are doing ABIs on the initial patient assessment on a diabetic foot? Shame on you. So the rule of thumb, and this is an American College of Cardiology guideline, any patient over 50 years of age with a history of diabetes and hypertension should have a PAD risk assessment. Part of the PAD risk assessment is doing an ABI. Okay, that is a level 1A guideline. You do that, and you are going to be clinically covered, okay, and legally covered, okay? If the wound is less than a square centimeter, can't do it. Okay, that doesn't meet criteria. Or if the wound's greater than 200 square centimeters. Okay? If there's carcinoma, fistula, all these things have to be checked off your clinical context. Why? These are all no-goes. Okay? This is the equivalent of, say, the bathroom not working on the airplane. It's a no-go. Okay? And obviously, if there's uncontrolled infection or evidence of osteo. So you have to have a medical necessity statement. Yeah, everybody's camera should be up right now, okay? You have to state that the wound on the extremity shall expect to close within 20 applications. This is your reasoning for using the product, okay? And this is going to be within your own words, and this is how you're going to basically document why you want it. okay? And you have to have an expectation. The patient should have a good prognosis and a good outcome and is expected to heal, okay? I doubt you're going to say that we're going to do all this and the patient's still going to fail therapy. I put it in there for completeness, but again, you have to have a reason for your outcome, good outcome, poor outcome, or failure of therapy. In the plan section of your progress note, you have to have an operative report, okay? Does everybody know the full, complex, detailed operative report? And I know not everybody's a surgeon, so those that are surgeons learn this, but if you're primary medicine doing wound care, you're not going to learn this, but you need to know this. So we're going to go over it, okay? The surgeon. Surgeon doesn't mean surgeon. Surgeon means the person who's done the procedure, okay? You must have a pre- and post-op diagnosis. You can say same for post-op, but it's got to be in there, okay? You list the procedure. Application of ActiGraft Pro to X extremity. Anesthesia. Are we going to just do this without debriding the wound? The recommendation is to have a healthy bleeding wound bed devoid of all non-viable necrotic tissue. So most of the time we're going to do that with local anesthetic, okay? Again, if the patient's a severe bleeder, you may apply a tourniquet, you may not. You have to document EBL. You can say minimal or none, but you have to document EBL. That is a necessary part of every op report. Medicare will ding this for an EBL omission. Materials, and this is the stuff that comes in the kit. This is your steri strips to anchor and not surgically fixate, but to anchor the graft, okay? And then any complications. Did the patient have a psychosomatic episode? Okay, did they have a syncopal episode? Did they have to go to the bathroom in the middle of the procedure and something happened? Just anything that happens on the patient during the procedure you have to document. And then your body of your report. So this is kind of how it's going to look, okay? Here's how you document your chronic and your metabolic diagnosis wound codes, okay? So the E11621, and I want to make this very clear, at least with First Coast Service Options, which is Novitas as well, and CGS administrators. So that's Kentucky, Ohio, Texas, Oklahoma, Mississippi, Arkansas, Florida, Puerto Rico, VGI. Is basically the E11621, if that's a primary diagnosis code, they will reject the claim straight out. Okay, unless it's tied to a debridement visit. If this is tied as a primary diagnosis code to this procedure, it's an automatic bounce. Okay, they want to see the E1140, they want to see a metabolic code listed first. Okay, so the E11621, in my experience, has always been a tertiary code. Okay, doesn't mean it's not valid, it's just not a primary ICD-10. The procedure is the application of the ActiGraft Pro, autologous whole blood clot. That's how it gets phrased. That's the product name. That's the procedure. And then either left or right foot. The report is patients placed on the exam table supine, okay, or prone, or left lateral recumbent, however the patient is. You want to document your timeout that you identify the patient, the surgical site, the surgeon, and the procedure of record. And that's what we call the JCO timeout. If you work at an HOPD, this gets done every visit. You just don't always do it verbally, but it's documented in the HOPD chart. If you're in a private office setting or an independent clinic, then you should still document this. You still want to make sure you're still doing the right side procedure stuff. Then you're going to make your narrative that you're marked and thoroughly selected, debrided of all non-viable necrotic and fibrotic tissue to your depth, which you document. Then you're going to talk about the extracting of the 20 cc's of whole blood as the phlebotomy procedure. And then the autologous clot was was formed per manufacturer instruction in the tray. You're going to document the amount of time you spent clotting, because that's everything. This is basically the narrative of what happened. This is your only defense to what happened during the procedure. It's not enough to say, patient came into the clinic, ActiGraft Pro was applied, patient left. It kind of doesn't, it really doesn't work too well. And then the Telfa, the non-adherent foam, the 4x4s, and the half-inch steri strips are all supplied by Red Dress. Those are all in the kit. That's why they're in the report, right? Okay? The Curlix and self-adherent bandage is add-ons for whatever you use extra. You can use cling, bulky dressing, whatever your dressing of choices in your clinic. And then you want to have a disposition statement that says the patient tolerated the procedure and anesthesia if necessary and was discharged home and will be followed up in 1 week. So that's your disposition. So that's a complete operative report. And the best part is if you do that, that's kind of your plan documentation. That's your procedure documentation. You don't have to double document. You don't have to say, again, later in the chart record, patient was seen and discharged for 1 week follow-up. You've already kind of covered that.